We stopped bantering. All right. Well, we are here for the last presentation in our series. And I was thinking about this today. What movies are there really great sequels to? And so we'll never know if these three series were that if they matched up well, but we'll see today if we can wrap up this series in a way that they're all just as valuable as the first one. But we have some new guests here today. A new guest, Corey. Welcome to the studio.
Thanks. I'm excited to be here.
And we have Jeff and we have Brad. Welcome again. Always good staples to our webinars. And Laura and Don Terry, welcome remotely as well. I'm Steve Kirschke. This is our webinar series for February. If you are new to QLI and new to our webinar series, QLI is based in Omaha, Nebraska. We're a post-acute rehab facility, and we also have an outpatient tele-rehab program, all specializing in traumatic brain injury, spinal cord injury. We have a small chronic pain program, limb loss program, and do a fair amount of stroke rehab as well. So those of you who are regulars in our webinar series, welcome back. We appreciate your ongoing support. Before we turn it over to Corey and Jeff, just a little bit of housekeeping. We've tried to simplify this even more for you all. So we do get several questions on how to get your CEUs. We are working very hard to make that very easy for you. But just as a reminder, before we get to the CEU stuff, if you have questions, use the Q&A. We will monitor that throughout the presentation. In order to get the CEUs, we just ask that you spend the whole time in the presentation. There will be one poll question at the very end of the presentation. There's actually a slide now that will denote when it's going to pop up. So if you don't see that slide, there hasn't been a poll question. We've also simplified the process to fill out your evaluation in order to get your CEUs. So normally you will get an email following this. The difference is that as you click end to this webinar, the jot form is going to pop up immediately, and you will have the ability to fill that out and click submit, and then you will get your CEUs following that. So we've skipped a step. You will not receive an email after this with a link. The link is immediately following the presentation. We will remind you again at the very end. So with that, I'll turn it over to Jeff and Corey. And Brad, I think you're going to kick us off with the objectives.
Yeah. So again, as Steve mentioned, if you've been with us for the last few webinars, we've been going through a series on balance, and today we are covering the visual system. So objectives are up here. You guys can read them. You can see them. We're going to kind of go through some of the visual system to start off with, understand the anatomy and the mechanisms behind the visual system. Dr. Snell is going to cover a lot of that and help us to understand the way that that's working inside of our brain and our eyes. And then Corey's going to help us kind of cover and figure out, hey, how do we actually assess the visual system and how does it influence our balance? And then go through some different techniques for addressing issues of the visual system, as well as any strategies that can be helpful with rehabilitation moving forward. So we can hit the next slide here. We kind of covered this last time too, but balance is a concept that is difficult to measure because it includes a number of characteristics and attributes. So oftentimes, for you guys, you might have a patient that is having issues of balance, and we have to make sure that all of the systems that we've been discussing, vestibular, visual, and somatosensory, are getting addressed within the rehabilitation setting, or are being parsed out appropriately to understand which one of those systems is most likely impacting an individual's balance. And so with that, I will turn it over to Dr. Snell to start the presentation for us.
Thank you, Brad, and welcome everybody. Welcome back to those that have joined us before, and welcome to anyone who might be new. We are going to be talking today about the primary components that contribute to various degrees to what we call balance. The inner ears, commonly called the vestibular system, our eyes and our visual processing that we call the visual system, our ability to know where our body parts are in space, that are known as the somatosensory system or the proprioceptive system. So in previous webinars, we covered vestibular and proprioceptive. Today, we're going to do a dive into the visual system and its role in balance. So balance is a combination of all these sensory inputs, integration, processing of that information, processing both at a conscious and an unconscious level, and the resulting motor output. We, again, covered vestibular functioning at the end of last year, so we're going to take that off this graphic. And in January, last month, we covered the proprioceptive system, so we're going to take that off. Now, you will notice that that really didn't change a lot with motor output. At the motor output stage of the chart, there are a couple of aspects of motor output involved in balance that are exclusively associated with vision. The vestibulo-ocular reflex and the motor output for controlling eye movements. Both of those motor functions have the potential to adversely impact balance. So vision plays an important role in balance. I want to repeat that because you are going to hear that again later. Vision plays an important role in balance. Now, let's begin by a review of human vision, and we'll start with the visual receptors, the eye. Our eye contains biological components that are the transducers that take in one form of data and convert it into something our brain can use to form perception. So basically, it turns light into neuronal firing, which the brain interprets as sight. The lens of the eye intercepts a cone of light that is then focused on the retina. Our sense of vision is something that we rely upon in interacting with the world. It's considered our dominant sense. It is something that provides a significant amount of information that's ultimately utilized to determine an appropriate motor and or cognitive response to our environment. As an object is closer or further away, accommodation muscles alter the shape of the lens to maintain focus, and the muscles move the eyes to maintain binocular vision, to create a three-dimensional perception of an object. Through parallax alignment, the brain can generate an estimate of distance of an object. When something gets really close, our eyes get pulled inward and appear to be crossed. That is called convergence. Divergence, on the other hand, indicates attending to an object that is further away. The brain has the ability of taking those minute measurements of deflection and comparing left and right visual deflection to give us a sense of that depth or distance. It's actually how a rangefinder works as well. You have two mirrored images of an object as you're looking through the viewfinder, and the distance between those and the deflection necessary to align those objects is what gives you the mechanical calculation of distance. It's how older cameras actually used to be focused. But our brain is capable of utilizing that angle of deflection to be able to calculate how far away we think an object is. Light enters through the cornea. The iris then either relaxes or contracts to mediate the amount of light that is entering the eye. The iris widens or constricts the hole through the iris, the pupil, through which light passes into the eye. Next, it passes through the lens, which focuses that image on our retina, which lines the back part of the eye. The retina is made up of light-sensitive photoreceptors, rods and cones, which send signals downstream based on the light coming in. That then is filtered down to the optic nerve, which sends that cumulative information that the retina gathers to the brain for processing. Now, here you see a graphic depiction of these sensory receptors, and you get an idea of why they're called rods and cones. There are around 120 million rods within a retina, and there are around 6 to 7 million cones, much fewer in terms of the number of cones as compared to the number of rods. Rods are involved in vision, especially perception, visual perception in low light conditions. Rods are not sensitive to color, but they are much more sensitive to the perception of the presence of light. Cones, on the other hand, are sensitive to different wavelengths of light and allow us to perceive color. Visual acuity, or resolving power, is the ability to distinguish fine detail. And that's also a property of cones more so than rods. Cones are not evenly distributed there on the retina. There's a much higher concentration of them in the center of the visual field, that visual field representation that is reflected onto the retina. And that area is called the fovea. The fovea is noted in the figure on the right to be roughly in the center of the retinal field, and you can see that the distribution of cones peaks in the fovea. The color blue on that ratio graph reflects the number of rods in a given area of the retina, with red showing a much higher concentration, blue showing a lower concentration. So you can see that rods are fairly densely distributed everywhere except that central foveal region. The fovea is dominated almost exclusively by cones. The information gathered by those rods and cones gets filtered through the layers of horizontal cells, bipolar cells, ganglion cells, and eventually converges to the optic nerve, which is also known as the second cranial nerve. You can see in the figure on the right that the optic nerve is slightly offset from the center of our retinal field. In the graph on the right, the little black spot to the left of the fovea represents where the optic nerve is exiting the eye. So that spot has no rods or cones. We don't see the absence of vision because our brain actually creates sight from the information coming from the eye. Now, that cranial nerve where it exits the eye and there are no rods and cones, it's a little offset on different sides of our left and right eye. And so as a result, the brain is able to take information from both eyes to fill in the missing piece from the other. The really interesting thing here is that if you close one eye, you don't notice that blind spot. And that's because the brain is amazing at approximating what should be, from the standpoint of sight, what is actually missing in that spot. And it just makes it up for you. So it just fills it in. It's only in very unusual conditions where you can notice that missing piece of information. Now, again, all of those rods and cones, about 125 plus million receptors, gets funneled down to the optic nerve, which is a bundle of between 0.7 to 1.7 million nerve fibers. So it is a myelin-covered pathway that's almost entirely within the brain. Most of the fibers terminate in the lateral geniculate nucleus of the thalamus, and that's where information is integrated and coordinated with other sensory mapping to create a perception of three-dimensional world around us. According to the Neuro-Optometric Rehabilitation Association, approximately 20% of our optic nerve fibers interact with the vestibular system. So that is a pathway by which maintenance or disruption of balance may occur. From the receptors, visual information coming from our left visual field hits the right side of the retinal field in each of our eyes. Now, it's represented on this graphic here by red information and the red path through the brain. The optic nerve forms an X-shaped pathway before the first, well, I guess you would call it transfer point for visual information, and that occurs again in the lateral geniculate nucleus of the thalamus. It is there that integration of our visual information is coordinated with other sensory inputs to give us a three-dimensional representation of our environment. In other words, information from our tactile senses, proprioception, vestibular information, hearing, smell, all of these component data and many others come together and are assembled into a meaningful representation of the world around us in terms of afferent incoming sensory information. When you hear a loud bang, you reflexively turn and look in that direction. Your eyes automatically go to the spot identified by your sense of hearing because those senses are linked. That linking occurs in the thalamus, in the lateral geniculate nucleus. You can also see that the left visual field, represented in red here, and the right in blue. Light from the left visual field, again depicted in red, enters the eye, hits the right side of the retina in both your left and your right eye. It is at the optic chiasm, the formal name for that X crossing, that the left visual field information from the left eye crosses over to the right hemisphere of the brain and joins the pathway of the left visual field information coming from the right eye. So from the optic chiasm, left visual field information from both eyes is processed in the right hemisphere of the brain. It all crosses in that chiasm. And right field information goes over to the left side. The superior colliculus is a sensory motor structure in the midbrain that's specialized to locate, detect, and orient our attention, and to direct motor activation necessary to attend to and further perceive information regarding that initial stimulus. In other words, when you attend to something visually, the superior colliculus is driving the muscles in your eye to keep your eye pointed at what you are attending to, whether it is moving or whether it is still. It accomplishes this through connections downstream to the nuclei of 3 different nerve centers that send out cranial nerve information. The oculomotor nerve, which is our 3rd cranial nerve. It's important for focusing on an object, for looking up, down, and fine adjustments in side-to-side movement. Also next is the trochlear nerve. That is important for looking down or turning the eyes inwards. When you cross your eyes, you're pulling the muscles that are controlled by the trochlear nerve. And then the 6th cranial nerve, which is the abducens nerve, and that controls the muscles that pulls our eye away from midline, that pulls our eyes in an outward motion. The vestibulo-ocular reflex, the VOR, is an automatic process by which eye movement is stabilized to maintain a steady retinal image of whatever we're interested in when we are moving our head. So I'm going to put a red dot on the screen here, and I'm going to ask you that you focus on that red dot. Look at the red dot. Now, while continuing to look at the dot, move your head around. Point your nose to the left and right, up and down. As you move your head around, you'll see that your eye stays very stabilized on that red dot. That is the function of the vestibulo-ocular reflex, to maintain central vision on a target. It would do the same thing if the dot was moving around the page at the same time you were moving your head. It keeps focus on the target. Now, when we covered vestibular functioning a couple of months ago, we talked about the semicircular canals in our inner ear and how our semicircular canals provide information relative to 3-dimensional rotation and movement. When you turn your head up, down, side to side, the semicircular canals are activating and sending signals to the brain to detect that movement. When you focus your central vision on a target, that target is maintained by monitoring information coming from the semicircular canals and sending excitatory and inhibitory information to the correct eye muscles to maintain your eye pointing at the target. It's really similar, if you know how noise-canceling headphones work, as they monitor sound coming in, and then they offset that sound with wavelengths of the same frequency and amplitude, but in the opposite wave motion. So as a result, you get a decrease of that ambient sound coming around. So what's happening here is when movement is detected by the semicircular canal, that information from the vestibular system determines the speed and rotation to counter that eye movement. So left, right, up, down, and even rotation, those signals are sent to the eye so that they can stay on a target. Now, we looked at the primary pathway of the eyes to the primary visual cortex, which is in the occipital lobe. But from there, that perceptual information gets routed to numerous areas within the brain. Just to give you an idea of the importance of vision, nearly half of the caudal or posterior aspect of the cerebral cortex is dedicated to processing visual information. So it's no surprise that vision plays a critical role in many aspects of our physical functioning. View A on the left is the lateral surface, the outside surface of the cortex, and view B is the medial view, the inner fold area. Once visual information is processed by the occipital lobes, that's where actual perception of vision occurs by the brain. You have cells within that area that detect edges, contrast, light versus lack of light, vertical objects, horizontal objects, all of the component aspects of vision are processed deep within the occipital lobe, but then that information gets passed on. Once visual information is processed in the occipital lobe, the first major pathway sends it up to the parietal lobe, where we become consciously aware of our sight. That's where information is then distributed to numerous other areas of the brain. The areas to which that information is distributed allows us to identify, recognize, categorize, name visual data. Again, left hemisphere language functions are located in the parietal lobes, the temporal lobes, the posterior and anterior aspects of the temporal lobes. So when you see an object, your categorization of it, what is it called? What is it used for? What is its function? Those are all concrete things we have learned through life, and it is an associative aspect. The parietal lobe is primarily considered the associative aspects of our brain. So it's distributing that information to what we need as far as recognizing something, and then also what to do about what it is that we recognize. When you read a page, you're taking in visual information, which you are translating into words, the meaning of those words, and then even the emotions associated with it and all the other sensory information that you've learned throughout your life. It is really, really complicated. All that distribution, evaluation, planning, and action occurs amazingly quickly. By way of example of that, have you ever looked down and seen a piece of rope or a vine near your foot and thought it was a snake? If so, you know just how fast your brain takes in visual information, processes it, passes it on to your awareness, and makes decisions or actions necessary, and even begins the motor activation that makes you reflexively jump away from a perceived danger. Although it's an amazingly complex system, it is an amazingly fast system as well. It has the potential to certainly dramatically impact our perception of movement, and it gives us a sense of context for where we are in space. When it comes to traumatic brain injury, where diffuse axonal injury may slow down how fast our brain processes information, you can certainly see how that slowing of processing can also affect multiple different areas as well, including movement. And when speed of reaction and speed of movement are compromised, that has the potential to radically impact our balance as well. Okay, that was a fire hose of information in a very short period of time. That was a quick review of vision from a neurological perspective. For our purposes today, though, what we're primarily interested in is how our vision interacts with other primary components of balance, our vestibular and our proprioceptive systems, and how all of these together contribute to balance. We also want to talk about how disruptions of vision contribute to degradation of balance or put us at risk of injury, and how to treat those disruptions when they occur. Now, in rehabilitation, the real so what of assessing and treating disruptions is something that primarily falls within the realm of occupational therapy. We are so lucky at QLI to have experts like Corey that we can turn to when vision and balance are at issue in a case, and in traumatic injury, they frequently are. So, Corey, I'm going to turn it over to you so you can further detail the types of visual disruptions that we see and how they're treated. Corey, it's all yours.
Thanks, Jeff. I appreciate that. And what a wonderful synopsis of our vision system. And I appreciate you setting the ball on the tee for me here. So as the occupational therapist, we're lucky enough to get to do the fun therapy and the recovery of things that are going wrong with the visual system. And we start with every client who has sustained an injury like this, a traumatic brain injury or a stroke, and we say, let's screen them out and figure out what is going on, and that helps direct our next steps. And so I'll first kind of go over our functional vision screen and what are we trying to tease out. It's really on someone's second day with us from an inpatient perspective, and I'll briefly go over these areas. Visual acuity, we're trying to figure out, can they see sharp, up close, far away? Is it impacted by their brain injury, or is it truly that they just need a pair of glasses, and we can refer out for that? Do they have a field cut, one of those big nasty homonymous hemianopsias, and say that 5 times fast, right? And where they're missing a good chunk, sometimes upwards of 50% of their visual field, and sometimes aren't aware of it. There's often a misalignment with their eyes as well, where we see one eye drifting outwards, inwards, upwards, or downwards, which we'll get into some of the therapy for that. Sometimes there's double vision. They have a horizontal double vision plane. They'll have a vertical double vision plane where they're seeing 2 of everything. And sometimes, in some cases, they've got a horizontal and a vertical, where that image is at a 45-degree angle from another one, and it is harder than heck for them to delineate which is which, and sometimes they really can't. And other times we'll see some suppression of an eye, which means the brain is essentially saying, I don't like what that eye is experiencing. I'm going to flip that light switch off. And now that person is really only using one eye, even though we think we're looking, they might look like they're looking through both eyes. Motility and pursuits, we're trying to figure out, can they scan their environment smoothly? Are their eyes jumpy? Do they miss? Are they not smooth? We rely so heavily on eyes moving and smooth planes to have good vision, which results in good balance, obviously. A saccadic movement is our ability to really jump our eyes back and forth fast. Can we look around our environment with speed and accuracy? And a lot of times, if we have some of these other disruptions, that is severely impacted as well. And I know Jeff mentioned a convergence and divergence deficit, which is relatively common. Our inability to go cross-eyed well, which helps us see things close to our face, and then our inability to diverge well, look at things far away and accommodate those images quickly. Anytime we're not moving quick enough, it makes it hard to process everything that's going on around us. A couple other things: photosensitivity, essentially those fluorescent lights in grocery stores that just kill the eyes. Sometimes that can be an issue after some of these injuries. And then the last thing is we want to assess, head tilts and body positions. If someone has a cervical issue and their head is tilted to the side, that's going to impact vision and balance. And so that's what we try to look for. And then what do we do with the information, right? How do we decide what's next? In conjunction with neurooptometrists or neuroophthalmologists, the occupational therapist is going to collaborate really closely once we've identified some things that are areas of struggle. Neuro-ops, I say it like that because I kind of classify both of these specialists in together. You get to really choose what direction you want to go. A neurooptometrist is going to focus on that eyeball and the processes of that eyeball, and what can we give the eyeball to see better. The neuro-ophthalmologist is the medical doctor that's got the training in the eye and the neurological processes of the eye, and can look at things through a different scope if there's ever any sort of surgery or medication that could be appropriate. Your neuro-ophthalmologist is going to be the route we go. I'd say typically a neuro-optometrist is consulted first when we have something going on like these below. And so I'd say these three on our slide today are our biggest deficits we see, are most common deficits. I know I mentioned our field losses, so it's a decent visual of on our left here of what someone sees and how they truly are missing that entire left side of their visual field within what is the common treatment plan. High intensity cueing for head turns and eye turns to that impaired side. Sometimes we talk about a triangle technique where we have someone look to their left lower corner, their left upper corner, and then back to center in hopes that they're getting all of that environment. And I want to put an emphasis on the high intensity cueing because it takes the treatment team. It takes everyone involved, and it takes all of the humans that this person is working with to provide that repetitive cueing throughout their entire day to really develop that implicit routine of looking lower left, looking upper left, and then back to center to really make sure they're not missing things on their left. Our center diagnosis, or our center deficit, is this misalignment. I know I mentioned an eye can be inward, upward, downward. There's fancy words for hypotropia, exotropia, really the strabismus effect on these eyes. And what we have to tease out here is, are they suppressing an eye, or are they having double vision? If they're having double vision, that's where we get to really get creative with our neuro ops and potentially implement a prism lens. I know there was a question about the prism lens came up in the chat. And so for those that don't know, a prism lens, that prescription is going to come from our neuro ops, and it is a specifically measured lens that goes on a pair of glasses, typically one lens, that helps move the image that's coming in from that pair of glasses. It doesn't move the eye, it doesn't change the eye, it changes the position of the image that person is seeing, hopefully to help fuse, or to at least get it closer to fusion. With someone who has double vision and is appropriate for a prism lens, the vision therapy is all binocular, meaning we're going to work really hard with both eyes all the time. We never want to isolate because we need those eyes to start teaming again and working together as a pair versus individually. On the other hand, if we notice that we're suppressing an eye, meaning that brain turned the light switch off and is no longer happy with that eye, it's going to look very different. We're going to be training monocularly, meaning one eye at a time. Typically, we'll spot patch for short periods of time the strong eye, the good eye, the eye that is functioning, that's not suppressed, in hopes that that brain naturally flips on that light switch to the suppressed eye. This looks different than pediatric developmental vision therapy. It's a reverse theory of what we do with some of our kiddos. Sometimes we want that eye to turn on and we want to get it back going, and we want that brain to stimulate that area of vision. And so it's challenging. And I've got a good picture of it here in another slide or two for our folks to see. And our third most common issue really is that convergence and divergence deficit that Jeff mentioned. So inability for eyes to go in and look at things close, inability for eyes to go out together and look at things far away. And really we focus on depth perception exercises, meaning look and work at different depths of our environment, up close, far away, 2 feet, 3 feet, 4 feet. Really, what is hard for that person? We would tease out, is it everything up close, your laptop, your cell phone, or is it stuff that is 10 feet away from you? And we would work hard to really focus on their depth perception. The kicker about convergence and divergence work is it takes a good level of cognition. So sometimes in the acute phases of these injuries, someone may not be appropriate for that just yet, but we want it on our radar for things down the line. Go ahead and pop that next slide for me, Jeff. We always ask the question, then what is the clinical relevance to balance? How do these get in the way of our balance system? And sometimes the answers are really obvious. Like with double vision, you can't sit on the chair if you don't know which chair is the real chair, right? And you can't step over the curb if you don't know which curb is the right curb. And so that double vision can throw us off, especially when you have a vertical plane, or sometimes that 45-degree plane set of double vision where it feels like your axis is a little bit tilted and you really can't delineate which is which is real. It can be really challenging. With suppression of an eye, remember that's that light switch turned off on one of the eyes, we don't have three-dimensional vision. We don't have depth perception if we're only looking out of one eye. If you close one eye right now, and everyone, it's early enough, I think, for everyone to still have maybe a coffee cup in front of them, close an eye and reach out for your coffee cup, and you're gonna notice like that is just a little bit different than if I'm looking through both eyes. And that can imagine walking around your environment. Imagine trying to play a game, play a sport, do all the fun things in life with your suppressing an eye. And don't get me started on driving with a suppression. We don't recommend it because you don't have that three-dimensional depth perceptive vision. And yeah, Brad.
I just wanted to chime in. My wife has one eye that is kind of suppressed, and I will not let her parallel park. It's hard. It's really hard.
I have a good buddy of mine lost an eye, and he golfs, and I will never understand how he is as successful as he is at golfing because he is only looking out of one of his eyes. It is wildly challenging to do your world looking out of one eye, especially add in a cognitive injury, add in a physical impairment. All of those things can challenge you for sure. Clinical relevance to a field cut is probably the most obvious one that you probably can't step over and miss what you can't see. So if you're missing things on that left side or the right side, depending on what side your field cut's on, or that peripheral vision loss, you're probably going to hit it. You're probably going to step on it and lose your balance and have a heck of a time trying to regain it. So there's some pretty simple real life clinical relevancies to balance in general. So, and next is the fun part. Next is I'm going to show you guys how does someone go from A to Z with these neurological vision impairments. I'm going to specifically talk about a misalignment, or again, we'll talk about strabismus. They're all relatively like interchangeable, synonymous terms in this vision therapy, visual rehab world. And for the record, this is the same human, and this is about a 4-month window from start of vision therapy to end of vision therapy. We were really the first folks to start doing some of the vision stuff with this person from an acute perspective. This person was ready for it. So top left photo is a good example of some ptosis of the eyelid, where that eyelid just doesn't want to cooperate. And you guys can tell her right eye is her dominant eye. Picture below her is her looking up into the air as hard as she can just to try to open that left eyelid. And you can see how misaligned that left eye is. She's got one of those, again, vertical and horizontal, where she is down and out with her left eye. And I know I mentioned suppression versus double vision, she's suppressing. We took her through a couple assessments, and yeah, she's suppressing. She's not reporting double vision. So that tells us, let's spot patch that good eye and force her brain to use that left eye. Jeff, I think you said it good yesterday when we were prepping. Constraint induced movement therapy of the eye in a roundabout way, right? And so you guys can see it's a plane of fake dress up plano glasses with some clear tape on top to really force that left eye to come into action. You can tell the difference between what that left eye looks like in the middle picture and what it looks like in this bottom left picture. It is turned on. It is looking. She's seeing sharp. Vision therapy every day, working those eyes, movement, just like we would the body. We do this with the eyes, and then you're going to look at the top right picture and see, wow, that left eye is coming into center. That eyelid looks great. You go to the picture below that, and we're getting closer. The eyelid is almost back to what I would say symmetrical, maybe a hair off here or there, but we're getting closer. The bottom picture on the right side of this slide is her at rest right before discharge. And you can still see that left eye is floated outwards a little bit. Vertically, I think we're there. Horizontally, she's still a little bit onto the outside of that left eye. And I'm going to go to the next slide, Jeff.
Corey, just a question on this one.
Yeah.
I know it's going to be different for every case, but what was the time frame for this particular patient, if you can recall?
This was about a 4-month window of time, which feels long. In reality, it's not. You have to be appropriate for vision therapy early on in the acute recoveries of some of these injuries. You're just not appropriate for vision therapy. It takes a lot of cognitive processes to get along in these therapies, and we're heavily reliant on someone following directions. We can't make their eyes move. They have to be able to move them themselves and follow directions well. And so sometimes someone's appropriateness just isn't there. And in this person's case, by the time she got to us and was ready, we were ready to hit it hard. And again, I think it had about a 4-month length of stay with us, and we got pretty darn far. The picture above is where we started, and the picture below is where she ended. And the picture below is a good example of her trying to fuse the image. You can tell that there's compared to pictures on the previous slide. Go back one real fast for me, Jeff. Bottom right picture, and then go to the next slide, Jeff. And this picture on the bottom here are the same moment with her putting in maximum effort and not putting in maximum effort. So you can tell how much cognition, how much work goes into her fusing those images together just to bring that eye in a hair. This is probably the most successful eye case we've had in terms of where we started and where we finished. And like I said, it was about a 4-month process. There are times that there's not this much success, and you try really hard for long periods of time, and you might have perceived plateaus, and then all of a sudden you get a little bit more progress made throughout things. And at a certain point, typically it's that year mark, you can go in and have a conversation with that neuro-ophthalmologist about a strabismus surgery, a procedure, where if you still have a fair amount of misalignment, and are having double vision, that doctor can go in and help surgically straighten your eyes. They won't do it typically inside that year mark from your initial injury to allow as much natural recovery to happen as possible. We want to make sure that we're giving the chance for the eyes to recover as best as they can. And the hard part about all this is once you get there, you have to keep working, going, and doing. And it isn't something that just kind of finishes.
Corey, I know with a lot of issues, particularly with traumatic brain injury, fatigue is a huge issue. Do you see alterations in function on the basis of fatigue with eye muscle control as well?
Absolutely. Yeah, I think to the point I made towards the end there of how hard this gal is trying to get those images to fuse and to bring that left eye in, she's got an hour in her and then she's exhausted from it, versus if we just let her exist and let that eye float where it needed to, she's going to have a little bit longer, cognitive endurance in her to get things done throughout her day. But you can build that up. You can build that up really nicely. And there's a little bit of a technique to it, and just letting someone work, and then break.
Is there a point at which just a normal eye function kind of takes over and is no longer something that you need to have formal therapy for?
Yes and no. I mean, there's always going to be the chance that you need to have some sort of like maintenance-based program where you're checking in with your neuro op to ensure that you haven't deviated back out or had a change, especially if you've had a surgery. I know that the beautiful thing about the eye is that living your daily life is vision therapy in a roundabout way. Your eyes are moving up, down, left, right, converging, diverging, saccading all around your environment all day, every day if you're just out living your life. And so I think half of what we do is encourage functional participation. Go watch that hockey game. Imagine the amount of vision therapy that is there watching a hockey game in live. Pucks, humans, skates, back, forth, everything going on. There's some wonderful opportunity in life to just keep those skills going. Don't sit and watch TV all day. That's not going to help you.
So you're saying that going to a tennis match would be some of the best therapy that you could do?
As long as you're sitting on the side, don't sit behind them. I think that would, unless you're working on depth perception. If depth perception is the goal, sit behind them. If motility or a back and forth is the goal, sit off to the side. So.
Never thought of it that way. Yeah, where you sit in the stadium is going to depend on which processes you're using the most.
Exactly. Are there, Steve, any specific questions you want me to hit on
So
up
I
there?
would
There's a
just
couple.
keep going if you have other content. We have some questions around the vision or the prism glasses, some monopsia, suppression here. So if you want to answer those now, otherwise you can keep going if you're going to hit it.
This is the bulk of the clinical application. I know we're going to talk about, Jeff, you've got a piece next, but if you feel like I should hit on a few of
Yeah,
these.
why don't you?
Oh yeah, I think we got time. Go right ahead, Corey.
Let's take maybe the suppression. So we got are you monocularly training the eye that is being suppressed? There's a question around, can you always retrain the suppressed eye, or is it case by case?
Yeah.
So let's tackle that one.
For sure. So yes to the we are monocularly training the suppressed eye. So that was that photo. Jeff, go back one slide for me. That was that photo with the glasses there. So her suppressed eye was her left eye, and her right eye was her dominant eye. So we are trying to manually suppress her right eye for her, right? Make that brain turn it down a little bit so that left eye turns on, and we won't have her live her every day like this, because this is hard. This takes, that cognitive endurance piece we just touched on is highly relevant right here and right now. And so typically this would happen during our vision therapy sessions, which are about 30 minutes a day every day. And so short chunks of time at the beginning to really build up the endurance of that eye, because for some people that eye's been turned off for 3 months since their initial injury, since they get to us and get ready for vision therapy.
Would you say it's similar to like what we do with an upper extremity? So like forced use. So is that a similar analogy?
It is, yeah. That is literally the mindset. It's, I think, like Jeff, you said it good yesterday, constraint induced movement therapy for the eyeball.
Mm-hmm. So the question around, you got the one on monopsia, this question on the prisms.
In that case, we're good to go. I'll go ahead and move forward.
Yeah, I think you can have it, Jeff.
All right, great. So as with all aspects of rehab, it's important to keep the right amount of support needed at each stage of recovery. And I think that's what, Corey, you were kind of speaking to from the standpoint of the therapy that you were doing directly with that particular patient, and how you have to, it's a moving target. As a person is recovering, what you are primarily focusing on is going to change over time. So that the right amount of support, that Goldilocks amount of support at each stage of recovery. And you also need to involve all potential supports. Again, the natural things that help support what it is that you are focused on in your formal across the desk kind of therapy, but what throughout the day can the individual also be doing? It's also teaching and training for family and significant others that can provide that support as well. And this is a huge one. It's important to remember to focus on the whole person, not just the symptom or the impairment. You have to be aware of the emotional reactivity to this process. When you are forcing use of something that does not work very well, it can be very frustrating. Anytime you take on a new skill that you haven't attempted to do before, it can be frustrating to do because you're not very good at it to begin with, and it takes time to develop that. The neuroplasticity of changing our brain requires, all of the things that we've talked about before in terms of repetition and support and removing barriers. And so that entire process is going to impact vision, which is in turn going to impact balance. Another one, we didn't talk about this a lot, but you did mention it, Corey, and that is hemispatial neglect. And it's an awareness issue. Awareness for a patient's important in terms of motivation in order to engage even in therapies. If you aren't aware of a problem, you have little motivation or reason to fix it. Because vision is a dominant sense, awareness is present in most cases. But there is an exception to that, and that lack of awareness is typically limited to issues of hemispatial neglect. From a safety perspective, that is where you really have to have more external cueing, and you mentioned that that external cueing is being a big part. That external support is a primary means of addressing the increased risks of falls associated with hemispatial neglect. Neglect is an interesting thing as well, just from the standpoint of the different parietal, the left and right parietal lobe. The left parietal lobe, from a neurological perspective, seems to almost exclusively process right visual field information from an awareness standpoint. The right parietal lobe, from an awareness standpoint, seems to take in information from both visual fields. And again, that's a thalamic function more than anything else. What that means is if you have damage on the left parietal lobe, you still have the right, which gives you information from both the left and right from an awareness standpoint. But if you have right parietal damage, you can often have a dense loss of information because the left hemisphere is only focused on right visual field information from an awareness standpoint. So that's where you get that dense loss of awareness of your entire left environment, your entire left of your world. If a person with left visual neglect eats a plate of food, oftentimes they will leave everything on the left side uneaten, untouched, because they are not aware of it. That is when they try to copy something, write something, draw something. Some of the neuropsychological tests that I utilize early on are not really focused necessarily on vision, but vision is an important part of that. And so we have to look at it. Something as simple as horizontal lines on a page and having a person mark the middle of each line on the page. Someone with a little bit of left neglect will have a rightward shift of that perception. Someone with a dense left neglect will entirely leave the left side of the page blank because it does not exist for them. So that is something that you really have to look for from the standpoint of awareness and whether that that addressing that and whether or not that support is something that can be self-generated or needs to be more external in nature. When vision remains a barrier to balance, there's a number of adaptations that we can put in place environmentally to reduce the risk of falls. Decluttering and organizing from a visual standpoint is reducing the visual complexity of a given area. Some of this is just physical as well, clearing pathways and removing trip hazards. Those are things that just are a good common sense approach to trying to minimize falls. Because we're talking about vision and because vision is based on light, make sure you have good lighting. If it's a low light environment, adding more light can dramatically change the risks associated with some of the issues where vision and balance are connected. Also, utilizing contrast, colors and patterns that provide significant contrast. The reason that warning signs and emergency signs stand out from our visual field is because they have high contrast and bright colors or patterns. If it's something that you want to pay attention to, you don't want it blending in with the field. Large print magnification devices can be utilized when visual acuity is an issue. And then assistive devices, and this covers a whole gamut of things that are environmental controls, lights, temperature, anything that reduces the need to actually physically get up and adjust something, flip a light switch, adjust a thermostat. If you can do it by voice control, then you don't have to get up. You're reducing that risk. A talking watch. If you have an Apple Watch that has that capability, it just depends on which of the watch faces you utilize with it. Speech to text software for dictation. In other words, I speak and my computer types the words out for me. Your phone can do that too. Or text-to-speech software, where your device will read what is on the screen to you. Your phone has that as well. Both Android and Apple phones for the past several years have had adaptive software built into them. And it is really interesting. Most of us don't ever touch that, but it has very complex adaptive software associated with it. So we call it a phone. It's a lot more than a phone these days, and it has an amazing plethora of adaptive aids built into it as well. So to summarize everything, our inner ear gives us vestibular information, our eyes give us visual information, and our body's proprioceptive senses all combine by sending information to central aspects of the brain that then get distributed all over the place so that we can be aware of and maintain our balance, both consciously and subconsciously, throughout our movement, throughout our day. Here is a list of some of the visually based information that were utilized in pulling together today's presentation. And the next slide is, Steve, over to you. Polling question.
All right. As a reminder, have to fill out the polling question to get the CEUs. I'm going to go ahead and launch that now. While we launch the poll question, Corey, I'll let you tackle some of these questions that we have going on.
Awesome. Thank you. One of the questions, doesn't the brain eventually adapt to monopsy, or that monocular vision, if I'm understanding that question correctly? You're absolutely right. Over time, that brain, you will learn to live with it. When we get folks in this stage of recovery, our goal is remediation. We're trying to get all of that back. And so, while yes, if we just let it sit and settle, they'll learn to deal with it. They won't develop that three-dimensional vision. They won't develop that depth perception. They'll just get really good at compensating for it, and to where we wouldn't even realize it, that they don't have that. So great question. Yes and no, right? Another really great one down towards the bottom was, do patients experience diplopia or double vision after working on the suppressed eye? And then would that warrant the prism? That is exactly what we're after. You almost create a second problem in this rehab journey. They're suppressing an eye. We're working, trying to get that eye to turn that light switch back on. I know that's the analogy I've kept using, and we're going to create double vision, and that's okay because we can work on that too. We can help correct that, not only with prisms and vision therapy, but there's a surgical solution to that as well in some cases. And so, yes, it seems like you're working on one problem to then create a second problem, but then that second problem gets us closer to home. And so, great question, and great job connecting the dots.
It really is amazing how adaptable the brain is. Again, we talk about neuroplasticity all the time. There are some really interesting studies that have been, some of which you really kind of question, why in the heck would anybody do that? But it's interesting, the findings that come from it. There was a study that was done many years ago that involved large prism that actually flipped the visual information coming into the eye. In other words, wear these glasses and everything looks upside down. Your visual field is entirely flipped. And what they found in this study was, if individuals wore those and consistently wore those, not take them off and put them back on, but wore them all the time for 2 weeks. Again, this is one of those, why in the heck would anybody sign up for this to begin with? But when people did that, what happened was, the subjects in that study, the brain adapted. After about a couple of weeks or so, they realized everything looks normal. When you take the glasses back off, again, you have an adaptation period. It's actually much less than the 2-week period the first time around. But the brain can take a completely flipped image and turn it back right side up for you, even when you do it with external glasses. The suppression piece, my wife had cataract surgery a while back and previously wore glasses. And so when they, did the cataract surgery, they put a lens in one eye for vision correction that she needed and left the other one alone. And so she has both near vision and far vision. And her brain automatically suppresses one eye or the other, depending on what it is that she's looking at. Took her a little while to adjust to that, but it's to the point now that she doesn't, have to close one eye in order to see what she's trying to see, whether it's further away or close up. So that's just another example of the brain's ability to adapt, and how that suppression is something that can be an ongoing useful thing as well, that the brain can turn on or off an eye in a given situation when it's needed. From a visual standpoint, it's also just really interesting the degree to which you can look at part of a figure and your brain can fill in the rest of it for you. Oftentimes, what we are looking at might be partially occluded, but in our brain, we can fill out the rest of the pieces of the puzzle. We can fill in the missing parts. All right, Steve, anything on housekeeping you want to remind there?
I'm actually going to end the poll question. So if you missed it for whatever reason, you're going to have to send us a side email. The responses are in. I'm going to share the results.
Looks like we got 100% responding as well.
All right. And then I'm going to have Brad talk us through what we see here.
Yeah, absolutely. So as we've been discussing in the last several webinars that we've done, there are three systems, as we've talked about, that are providing input into our brains to help us kind of make sense of the world around us and to maintain our balance as well. Those systems are the visual, the vestibular, and the somatosensory systems. So in the poll question, at least, and there's kind of fancier words. So we put upper motor neurons in there. Upper motor neurons actually they carry information that has been generated from the brain out to the body to help muscles move, right? So it is not part of the balance system as we've been talking about it. Could be a little
I've got a technical point here.
I know there's going to be a technicality.
I've got a technical point. Yep, I want to raise a point. It is not a component of perception balance.
So what would happen in a classroom setting is this question would get thrown out because it's not really a valid question. So those of you that also raised the technicality on the poll question, bravo. We'd have to throw this question out, but thank you for answering.
We were trying to avoid doing the digestive system, which would make it even more obvious. And so then Brad came up with upper motor neurons. And full disclosure, we did this 5 minutes before we signed on. So
as a neuropsychologist, I could also make a technical objection to that as well, because most of the serotonin in our brain comes from our gut cavity, which involves the digestive system.
Jeff, you might not get it. Well, you're for sure going to get invited back, but we'll just chastise you.
Next poll question. Would you like to have Jeff write the poll question?
Next slide, please, Jeff. Just to round us out, we do have contact information for Corey and Jeff. If you have specific technical questions, any other sort of question, please reach out to them. Their phone numbers and emails are there. Also, one more slide on here, which will come in your CEUs. If you happen to have a referral, a question about a potential referral, or someone you're working with that is more on the admission side, please give us a call. Patty will handle those on our inpatient program. If you have someone on the more outpatient community-based, feel free to give me a call or shoot me an email. Happy to help, even if you don't have a specific referral. So we're here for you. With that, we'll let you go a couple minutes early today. Corey, thank you so much for joining us. I believe you'll get invited back too if you'll take it. Jeff, as always, we really appreciate you. Brad, thanks for your work, all three of you, on just putting together a terrific series. Laura and Don, thanks again for joining. And for those of you who joined us, we appreciate that. We will be back